Okay, so for lab maintenance, I'm going to clean our Catalyst 1 machine here. So what you do is you put on powder-free nitrile gloves, you have alcohol pads, and you have optic wipes. And so what you do is you open up the door, you're going to pull on this green lever and open up the carousel. We're going to remove the carousel and take a clean alcohol wipe. And we're going to wipe in a counterclockwise direction 3 times. And we're going to use a clean alcohol wipe in between every wipe. As so.
Great job, thank you. It looked like, when I walked in, it looked like nothing had happened.
Right. That was the wall.
And then we're going to take one of our optic lenses and we're going to wipe it clean. Then we're going to take another clean alcohol prep pad and we're going to clean our optic lens on our catalyst discs here in a counterclockwise direction and wipe all of those clean. We'll do that 3 times as well.
I know of bubbles.
So clean in between every individual one of these little discs with an alcohol wipe. Bye, have a good night.
I'm just gonna steal him. Don't tell anybody. Casey will never know he's at my house. It's not like she comes over there quite for me.
I might end up staying a little past 6 tonight.
Okay. And then we'll take another optic wipe and we're going to wipe everything dry so there's no residues. Everything's clean and dry in there, so we replace our drum. And we're going to close our lid and close the door. And our catalyst machine is going to run a self-check and the system's going to register that the machine has been cleaned. We do this once a month, and then a second time later on in the month we do a quality control check, and we do that on our grave shifts since they take so long and we're a really busy ER hospital. Okay, we are going to run a 4DX snap test as part of our ELISA testing. It can be run on ceraplasmin or anticoagulated whole blood, so we're going to use anticoagulated whole blood. I'm going to invert my sample 8 to 10 times just to make sure that it's thoroughly mixed. And then what we're going to do in our sample tube here is we're going to put 3 drops of the blood in the sample tube, and then we're going to do 4 drops of the conjugate. We're going to mix that together and put it into our sample well and let that run for 8 minutes. So we have our blood nicely inverted. We're going to use the pipette that comes in the IDEX Snap package, and we're going to do 3 drops of blood. And then we're going to hold our conjugate bottle vertically, and we're going to do 4 drops in the sample. And we're going to cap that up, and we're going to invert that 3 to 5 times. So 1, 2, 3, 4, and 5 full inversions. We're going to dump our mixed sample into our sample test well on our 4DX test that's been heated up to room temperature. And as soon as the color hits the color well up here at the top, then we're going to snap it down and allow it to read for 4 minutes and compare it to the results in the test booklet. And it takes typically about 30 to 60 seconds for the blood to come up the test and hit the color sample well. And in the case that in that 30 to 60 seconds your blood doesn't reach your color sample well, the instructions say you need to wait until you see the blood first appear in your sample well before you click down. And it's been about 60 seconds and our blood hasn't reached our sample well yet, so we're just waiting. And you can see just a smidge, it's starting to pop up in that color sample well, so I'm going to push down all the way. And we're going to wait 8 minutes to read the test. Okay, so it's been 8 minutes since we ran our 4DX snap test on our patient Jake, and comparing our color positive control to our interpretation of results in the pamphlet, it looks like our patient is heartworm negative. The purpose for running a modified SNOTs test is that it helps us differentiate between the different types of worms, and it concentrates the microfilaria, so we can differentiate between the dirofilaria and the acanthochilonema. And so what we're going to do, I only have a 6 ml test tube at my hospital, so what we're going to do with the instructor's permission is we have our 2% formalin mix, and we're going to put 4.5 mils of formalin in our test tube and mix it with 0.5 mils of anticoagulated whole blood, centrifuge that down at 1500 RPMs for 5 minutes, and then we're going to decant the supernatant. We're going to put a drop of new methylene blue in it, and then we're going to look at put a drop of that on the microscope, and then we're going to look at that under the microscope. So we're going to put 4.5 mils of our 2% formalin mixture. So there's 3. And 4.5. And we're going to take a syringe and get out 0.5 mils of our anticoagulated whole blood. We're going to mix that together. And we are going to mix that together. And again, we're going to centrifuge this at 1500 RPMs for 5 minutes, decant off the supernatant, put a drop of new methylene blue in there, mix it together with a pipette, and then we'll look at it under the microscope, see if we see any dirofilaria or acanthocynemia worms. Okay, so we have our sample here that we spun down at 1500 RPMs for 5 minutes. This is our 4.5 mils of 2% formalin and our 0.5 mils of blood. So what we're going to do is we're going to decant off the supernatant. Be careful not to disturb any of the pellet down at the bottom. So I'm going to decant off the supernatant. Okay, we're going to add a drop of new methylene blue. And we're going to use a pipette to get down in there and mix it up down in the bottom. And I have our microscope slide here and a cover slip. And we're going to take a small sample of that, put it on our slide, and look at it under the microscope. Scoot this over so we can see. Okay. So I'm seeing a lot of stained cellular clumps that look like red blood cells and white blood cells. Scanning from left to right, top to bottom. And this is on low power objective. Here in the state of Montana, we don't really see heartworms all that often. In my 4 years at this practice, I have seen 2 positive heartworm tests. We are more commonly recommending HeartGuard now at the recommendation of the American Heartworm Society. But scanning through this entire sample, again, I'm seeing some red blood cells and some white blood cells. But as I'm scanning through here, I've now reached both sides. I don't see either of the worms, so no microfilaria in this sample. And as the textbook says, doing a modified SNOT test is not going to find anything on an occult heartworm. To do a fecal flotation, what we're going to do is we have a Dixie cup here that we're going to put about 2 grams of our feces into. And we're going to mix that with our Fecasol solution here. And we're going to put a generous amount in there and make a pretty good mixture of the feces and the Fecasol together until it's relatively dissolved. And since this is one that we don't centrifuge so all the large chunks can go down to the bottom, I like to use both a gauze square and a tea strainer to make sure that everything has gone through. So once we have that mixed together pretty well, I take a tea strainer into a second Dixie cup and I put a little gauze square in there. And I dump our mixture in there and allow the big stuff to get caught into the gauze and the rest of the solution to drip down into our cup. And once we're pretty confident we have all that put together, we're going to set aside our strainer. And then we're going to, I have a test tube here labeled for flotation. I like to dump from our Dixie cup our strained solution all the way up to the top. We're going to allow it to form a very small meniscus at the top. And we're going to apply a cover slip and we're going to let that sit for 10 to 15 minutes. And then at that rate, we'll put it on the microscope on a slide and we're going to read it under all the objective lenses to see if we see anything. To run a fecal flotation with centrifugation, again, we're going to take about 2 grams worth of feces and we're going to mix it with Fecasol. Again, another generous mixture. We're going to combine that all the way together as normal. And since this one is centrifuged and all the heavier stuff is going to float down to the bottom, I'm comfortable with just using a tea strainer. So once we have that well mixed, I have my tea strainer that I'm going to strain into my second Dixie cup. And allow all the solution that's small enough to go through the tea strainer to get through. And then we are going to take another one of our test tubes and we're going to fill it with our solution just to the top of this white label. And we're going to centrifuge that. Here at this clinic we use 1300 RPMs for 5 minutes. And once it's centrifuged, we're going to put a meniscus on it with Fecasol and we're going to put a cover slip on the top of it. We're going to let it sit for 10 to 15 minutes. Then we're going to remove our cover slip, put it on a clean microscope slide and look at it under the microscope. Okay, so we centrifuged our 2 fecal samples that needed to be centrifuged. So that's our flotation with centrifugation and our sedimentation. So what we're going to do with our flotation with sedimentation is we're going to pop off the top and we're going to fill the rest with Fecasol. And so we have a small meniscus at the top. Going to put a cover slide on the top of that. And we're going to let that sit for about 10 to 15 minutes. We're going to take the cover slide off, put it on top of a microscope microscope slide, and then we will read it and determine results. For a fecal examination with sedimentation, what we're going to do is, again, we're going to take 2 grams of feces, and we're actually going to mix that with tap water. So I have a cup here with tap water in it. And we're going to mix that together just like we do with the Fecasol on any other fecal testing. And we're going to take a clean Dixie cup. Oop, there's one rolling around. And we're going to, again, use our tea strainer with a gauze square in it to catch all of the larger stuff. We're going to pour that through. And let it soak in, and once we're confident we have that soaked in, we'll dispose of our gauze square. And then we're going to fill our tube with our solution almost all the way full, so again up to that white label. And we will centrifuge this at 1500 RPMs for 5 minutes, or I'm sorry, 1300 RPMs for 5 minutes. And we're going to pipe it off all of the stuff on the top and dump that out. And we're going to use the pipette to get all of the fluid that, or I'm sorry, the fecal material that is sunk down to the bottom, and we're going to put that directly onto a microscope slide. Sedimentation is mostly used in large animal fecal evaluation, since the eggs that most large animals contract are too heavy to float in a fecal sol solution. So as soon as we have this centrifuged, we'll dump off the top like we talked about, use a pipette to collect the sediment down at the bottom, put that on a slide, and evaluate under the microscope. For a fecal examination direct smear, I have our bottle of fecal sol here and a clean clean microscope slide. We're going to put just a couple of drops of fecal sol on our slide, and we're going to use a tongue depressor to get a small amount of feces, and we're going to put it into the fecal sol. And I've got another little wooden applicator here to help us do that. And so what we're going to do is we're going to smear it onto our slide, and we're going to add a little bit more fecal sol because I put too much on there. We're going to smear it onto our slide, and it should be thin enough that we're going to be able to read through it. And I have a little garbage down here, and I'll move this. So we're just going to smear it across there, and we're going to get all the large chunks of feces off of our slide. So we have a sample here that's thin enough to read. There's still some fecal material on there, and we're going to look at that under the microscope. To perform an ear cytology, I have our little patient here named John. He is a kitten that came in from a rescue who's been shaking his head a lot, itching at it, and for a while had a little bit of the brownish black debris coming out when he shook his head, but he doesn't have that anymore. So what we're going to do is we're going to do an ear cytology on him today. I've got 2 swabs that we're going to use, one in each ear, and on the left one we're going to break off the base of it after we have taken a sample from the left ear. Then we're going to gently roll it across our slide, which I have here on the table, and we're going to heat fix it and use our 3 Dipquick stains to stain it and look at it under the microscope. So our little patient John here, we are going to do his left ear first. We're going to stick our swab down in there and roll it around gently so we get some stuff off of there. Again, we're going to break the top of the thing so we know which one is left. Set that aside, and we're going to do the same on the right hand side. We're just going to grab his little ear and we're going to stick it down in there, roll it around, and get a good sample. And both of them are coming off pretty clean. And we're going to put our little patient in my lap. We're going to take our slide, frosted side up, and we're going to gently roll our sample. And my right I do horizontal, and on my left I do vertical. Gently roll that on there. And we're going to heat fix our slide. Just a few quick passes to help melt that earwax on there. And then we have our ear cytology Dipquick stain set. So we have a separate for blood and we have a separate for cytology, things that are dirtier. And we use a little clothespin. We're going to dip these in here 15 seconds a piece. Okay, so now that we're done staining, we're going to set it aside to let it dry out. We're going to rinse it as well, but I'm not near the sink, so I'm going to go rinse it, and then we're going to let it dry off, and then we're going to read it under the microscope. Okay, for a dermatophyte test, we have our patient Olaf. We're going to use some thumb forceps to pluck a little bit of hair, inoculate it into our DTM medium, and we're going to partially cap the lid, put it in a dark place, and check it daily for the next 14 days. So we have our little lesion here, and we're going to pluck some hair from it. And we have a little sample of hair in there. We're going to inoculate it partially into our testing medium. If you can see, there's a little bit of hair in there. And we're going to partially cap it, keep it in a dark spot for the next 14 days, and check it every day. Okay, so we have Olaf's DTM medium that we pulled 14 days ago. We've been monitoring it every day, again with the lid partially capped and keeping it in a dark spot. So I'll show you what we grew. So this is Olaf's DTM, labeled with his name on it. And it's kind of hard to see, but he did grow some material. However, with confirmation with the doctor, we are not concerned about ringworm for this case, but it does look like we grew a little bit of mold or something along those lines. But the current answer is it is a negative on the ringworm test for our patient Olaf. To perform a skin scraping, I have a 10 scalpel blade here, a clean microscope slide, and our mineral oil. We have our patient Olaf, who has a lesion here on the inside of his groin that we're going to scrape. We're going to put a drop of mineral oil on the slide, and we're going to dip our blade in there. We're going to hold it perpendicular to our patient, and we're just going to scrape at the edge of the lesion, so we have partially normal skin and partially infected skin, and we're just going to scrape until we have a little bit of capillary oozing, which we're starting to get there. And we're going to dip that into our mineral oil, and then we will take it to the microscope and we'll evaluate what we see. Okay, so we have our microscope slide here that we used when we made our skin scraping. We've already dabbed our blade in the oil, and we're going to put a cover slip on the top, and we're going to look at it under the 4x objective on our microscope. Okay. So I'm going to try and locate the middle. And now I have our sample in view. I'm seeing some cellular debris. And I think I'm seeing some bacteria. I'm going to double check this with the doctor. And scanning left to right, top to bottom. But I am not seeing any ectoparasites, just some skin cells, and again, possibly some bacteria. Otherwise, the skin scrape looks normal, and hopefully it's just a irritation on the surface of the skin, but didn't see any ectoparasites present.
Alright, we're going to do a necropsy on this dog here. He has a lot of external tumors and recently died of fluid filling the lungs. So I'm really curious to know, after doing a necropsy, feeling external tumors here, 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 and here, and having fluid come out of his lungs, what else he has going wrong internally. We suspect there's going to be some masses on a couple different internal primary organs, such as the liver. So we'll incise along the midline of his body, so we can access all of the internal organs. This primary fat is called the falciform ligament. It's not a problem, we can just remove it. That is the bladder. This is a lobe of the liver, and it is incredibly friable. You want to try and touch that? Touch it firmly?
Ooh.
Yes, it just peels apart. That is an abnormal liver.
Biopsy?
Biopsy. So we get margins of where the liver looks normal to where it's completely friable. We take a biopsy.
And this is labeled with the patient's name, the owner's contact information, all information about the animals, and we'll label it on the top of where the biopsy came from.
Oh, that was a bad liver. Where is your spleen? This can be removed, it is just body fat. And there's your spleen. Spleen looks normal, it ended up being a hepatic mass with a normal looking spleen. There are small areas of necrotic foci, basically little infarctions and little dots in there, but no large masses. Still take a sample looking for infiltrates of whatever type of cancer there could be. Checking into the stomach. Pylorus looks normal. Good. Alright, now we're going to take a look at the adrenal glands and see if there's an adrenal tumor. They're located right near the kidneys, between the kidney and the aorta. The aorta is right here. They are not enlarged. Well, not greatly enlarged. And nothing to worry about there. Lastly, we will look at the heart. One second. Would you like to open the rib cage for me so I can get to the heart?
Right in midline.
Midline will work. You can go a little off midline so you don't just go along the sternum. Yeah, perfect. Yeah, that'll work. Now, as you can see, these lungs are congested, filled with blood. They're supposed to be nice and pink, and they are not.
He just had to have his pills.
That is the gallbladder, actually. Now we'll check for a heart-based tumor. You don't see any there. We'll take off the pericardium from the heart. There is no tumor on this heart.
There we go.
No tumors in there. No, that's not a tumor. Do you know what all these little things are?
Oh,
You got this, Allie.
it starts with a T.
Chorda tendineae.
Tendon, yep.
The little strings of the heart to play the heart's music. Other than that, looks like a liver mass, congested lungs. I suspect she was in heart failure, but not due to a heart-based cancer. And we'll find out if there was a cancer in the liver or not, or what was the cause. That's a wrap.
Okay, for rabies suspect handling in the state of Montana, we send all of our heads and bats and suspicious rabies animals out to the Montana State Bozeman Diagnostic Lab, and we have this form here that we fill out. So it has the veterinarian's information, all of our clinic information, the owner of the animal's information, as well as the animal's information, what we're sending out, and what we're requesting. So we have a filled out rabies suspect form for him already here that we filled out earlier for Dr. Katie Welch. And we also have an in-hospital form that we have them sign. So this is our rabies evaluation port. So we have the owner put what kind of animal, what kind of exposure, and what happened. So we have that there, and we also have our authorization for euthanasia. We take copies of all of this and we send it out to the lab. So what we do is with essential PPE, so we use masks, we use protective eyewear, we use gloves, and we use gowns. We decapitate the animal, we bag the head 3 times so that any contact with blood is as minimal as possible for the lab when they come and pick it up. And then what we do is we have our box here, and this is our head box. It's got a styrofoam box on the inside of it. And we take our rabies suspect triple bag and we stick it in our box and we pack it full of ice packs. So I've got a couple of ice packs here. We're going to pack it full of ice packs so it stays cold. Is we fold up our rabies paperwork. So this is basically our requisition to send it out to the Montana State Diagnostic Lab. And we're going to put that in a separate baggie so if the ice melts or something punctures or anything like that, that the paperwork isn't compromised. Put our paperwork in there with it. Box this up, address it to the Montana State Diagnostics Lab, and then we send it on out. We typically get results back. If it sends the same day, we typically get results back in 2 to 3 days, and then we call the owner and we let them know what the results are when they come back. What I forgot to mention in the rabies suspect handling video is we do have a certain number of staff that is rabies vaccinated. So I'm rabies vaccinated along with 3 other technicians on the staff. Typically speaking, if we're available, we are the ones that handle the body. If not, anyone can handle the body as long as they're wearing appropriate PPE, which we already discussed. And what we do with the body after we've decapitated the head and sent it out like we'd previously shown, we have a crematory here in-house, so we bag up the body 3 times, like we already discussed, and we let it freeze in a special freezer, and then we put it in the crematorium and we cremate and return the ashes back to the owner.
Alright, I'm gonna try and get a sterile vaginal cytology with Allie's help here. She's gonna pour some sterile saline into the gauze so that we have some, basically a sterile wipe so we can clean the vulva and make sure it doesn't have any extra bacteria or any other problems. Alright, will you help me hold the tail? We'll clean the vulva back here, making sure to wipe away from the anus. And so there's no dirt in this area. And then I will have Heidi hold the tail while Allie gets me the vaginal speculum so that I can appropriately get to the right spot. May actually wind up to be easier for me to do this, but thank you for handing me that. All right. She's very cooperative, and Allie, I'm going up at an angle in order to get into the actual vaginal canal. And then I go inward, and I gently swirl to collect a good sample of the actual vaginal area. All right. You see I have some discharge on this. We're gonna go make a slide.
Okay, for our vaginal cytology, we take the scratchy side of our slide, which is labeled Monroe down here. And we're going to take our sterile swab and we're just going to gently roll it on the slide. And then we're going to dip it in our cytology dip quick stains at 10 seconds a piece. Let it dry and then we're going to read it. Okay, we're gonna give it a rinse with sterile saline and then we'll give it a read after it dries. Okay, so Monroe's vaginal cytology has dried and I already took a peek at it. What I'm seeing here is compared to yesterday's vaginal cytology that we were reading, there's about a 40% decrease in the superficial cells, I'm sorry. And there's an increase in the intermediate and the parabasal cells. And there's a whole lot of cellular debris. So like I said, we're about 40% less than we were yesterday on the superficial cells, which makes sense because she's in the middle of a therapeutic abortion right now. So she is pregnant. We're on day 5 of lutealized treatment and we're just monitoring her progress every day to see how it's going. What I failed to mention in that video is that she is most likely in diestrus, which I verified with the doctor, since diestrus and anestrus are kind of hard to differentiate from when they're pregnant at the time. Anestrus is when the canine reproductive system is at rest. The vaginal mucosa is pale, the cervix is closed, and any vaginal secretions are very scant and few and far between. Microscopically, what we expect to see, the superficial cells are most likely not present. If they are, it's in very small numbers. The neutrophils and red blood cells may or may not be present. Intermediate cells and parabasal cells are what we see predominantly in vaginal cytologies that come from a dog that's in anestrus. During proestrus is when the follicle develops. It's also known as the follicular phase. The uterus enlarges, red blood cells leak from the capillaries, the vaginal epithelium proliferates, and as the estrogen increases is when the follicle is developing. Microscopically, what we expect to see, there's a mixture of intermediate parabasal and superficial epithelium cells that are all gradually shifting to superficial. It's not uncommon to see large colonies of bacteria, neutrophils might be present, and red blood cells are present in large amounts. Estrus is when ovulation occurs. What we expect to see at this time, the vaginal epithelium becomes hyperemic and has a large blood supply. We see an increase in progesterone and a decrease in estrogen. Microscopically, what we see is a predominance of the superficial cells. Almost all of them at this time are anuclear and almost all of them are cornified. It's not uncommon to see bacteria attached to the superficial cell. And we have the occasional erythrocytes may be seen and neutrophils are absent. Diestrus is also known as metaestrus. During this time, what we typically see is a swift decline in the superficial cells and the reappearance of intermediate cells and parabasal cells. It's such a swift decline that in a single day we can see a change from 100% superficial cells to 20% superficial cells. We also see an increase in the cytologic debris, so we see a lot more of that. It also is important to notice that diestrus and anestrus are very difficult to differentiate cytologically, and that also is what vaginal cytologies look like during the time of pregnancy. When they're in their gestational periods, that their vaginal cytologies look nearly identical when they're in anestrus or diestrus. For the beginning of our manual cross match, I've got my two dogs here. Groot is my healer. He's going to be the donor, and Ellie's my dachshund. She's going to be the recipient. I've got red top tubes and our purple top tubes here, and our red top tubes are clotted. So we're going to centrifuge that at 4,000 RPMs for 5 minutes to get everything to spin down, and then we'll start our erythrocyte washes. Okay, so to start our manual cross match, we have our two serum separators and our two EDTA tubes, which we've already spun down, as you can see here. And what we're going to start with is we're going to decant the plasma off of the top of the erythrocytes and the bottom of the EDTA tube. We're going to put those into two tubes we have labeled here for Ellie and Groot's serum. I have syringes to decant those off that have their initials on the top of them, so we make sure our syringes stay separated. And then I will show the process of how to start a suspension wash. So I'm going to take Ellie's syringe, and we're going to get all the plasma out of her sample and set that in a separate tube. Labeled for her. And we'll set that aside. We'll do the same thing for Groot. There's still a bit left in there. And we're going to set those aside for later. And then what we're going to do is we're going to take a new syringe and we're going to take 2 drops of the packed erythrocytes down at the bottom of each tube and set those into a new tube for the washes. So I have one labeled Ellie and Groot. And we're going to place 2 drops of Ellie's packed erythrocyte suspension into her wash tube. So 2 drops there. And set that aside. Clean syringe for Groot and do the same. So 2 drops of the packed erythrocyte suspension into a new tube to be washed. 2 drops for him and set that aside. Then we're going to fill the tube up the rest of the way. This is a syringe of sterile saline, 0.9%, and we're going to fill that up as so. And put the lids back on. And we're gonna gently mix these together. We're gonna centrifuge them at 3,400 RPMs for 1 minute. And then in the next video, I'll show how to do a wash. We're gonna do that 3 times before we make a 2% erythrocyte suspension. So I'm gonna go put these in the spinner and then I'll show you the rest. Just for demonstration, I have our 2 erythrocyte washes that we're going to start. Our first one, I have our centrifuge here at 3,400 RPMs for 1 minute. We're gonna spin that down and then we'll do our second wash, which I'll demonstrate in the next video. So I just took these out of the spinner. This is our first erythrocyte wash, and as you can see, there's the packed erythrocytes down at the bottom. So the next step is we're going to decant off all the supernatant, and we're going to wash it a second time and a third time. So we're gonna take another clean syringe, and we're going to syringe off all of the sodium chloride and dispose of that. And get off as much as possible without disturbing the erythrocytes down at the bottom. Okay, so I've got all of that pipetted off to the very bottom. And then we're going to, again, add more saline. Put the lid back on. Mix that together again, and then we're going to centrifuge that a second time. We're going to do that to both samples, so another brand new clean syringe. Get off all the sodium chloride. All right, and again, put in more sterile saline, or 0.9% saline. Put the lid on, mix it, and then we'll go centrifuge it again a second time, decant off all the supernatant, put in more sterile saline, do that a third time, spin it down at 3,400 RPMs for 1 minute, and then we'll make a 2% erythrocyte suspension at the end. Okay, so we've done our 3 washes. We're gonna take another new sterile syringe and we're going to decant off the sodium chloride again. Of both samples. Okay. We're gonna set that aside. And so we have 2 tubes. We have one labeled Ellie test tube and we have one labeled Groot test tube. Okay, I had to go get a smaller needle to get down into the bottom to suck up the fluid. So we're gonna take a new sterile needle that hasn't been used and we're going to suck up 0.02 of the erythrocyte suspension. And we're going to put that into the test tube labeled 2%, 0.02 of Ellie, and set aside her erythrocyte suspension. We're going to do the same thing for Groot. We're going to suck up 0.02 of his packed erythrocyte suspension. and put that in his. And then we're going to take a syringe and we're going to draw up 0.98 mils of 9% sodium chloride. And we're going to put that in our wash. And that's our 2% erythrocyte suspension to start our major minor cross matches. Okay, to do our major minor cross match, we have our serum coming into play now from both Ellie and Groot. As a reminder, we have Groot as the donor and Ellie as the recipient. We're also going to make majors, so I have the major, minor, Ellie's control, Groot's control, Ellie's erythrocyte suspension, and Groot's erythrocyte suspension. So what we're going to do for our major is we need 2 drops of the donor's erythrocyte suspension and 2 drops of the recipient's serum, and I'm going to make the controls at the same time. So I'm drawing up Groot's erythrocyte suspension right now. He's the donor, and we're going to, in our major, put 2 drops of his erythrocyte suspension, and in his control tube, 2 drops of his erythrocyte suspension, and set that aside. And then we're going to do 2 drops of the donor's serum, the recipient's serum, and we're going to put 2 drops of her serum in her control tube as well. So I have Ellie's serum here. We're going to draw up 2 drops and put 2 drops of the recipient's serum in the major, and 2 drops of her serum in her control, and set that aside. For the minor, we're going to do the exact opposite, and we're going to do 2 drops of the donor's serum, which is Groot, and 2 drops of the recipient's erythrocyte suspension. So for the major, I have Groot's serum that we just drew up here. So for the minor, 2 drops of the donor's serum, and in his control, 2 drops of his serum. Set that aside. And then we're going to do 2 drops of the recipient's erythrocyte suspension. And this is Ellie's erythrocyte suspension labeled test tube. Drop 2 drops of that. And we're going to do, in the minor, 2 drops of the recipient's erythrocyte suspension. And in her control, 2 drops of her erythrocyte suspension to mix with 2 drops of her serum. And set that aside. We're going to gently mix these together. And we're going to cap everything, and we're going to let it sit untouched at room temperature for 30 minutes. Look for gross agglutination, and if we don't see any there, then we'll look for microscopic agglutination under the microscope. Okay, so it's been 30 minutes since we put our slides, or our major minor to rest, and I was looking at them, and I don't see any gross signs of agglutination in either the major or the minor. So what we're going to do is we're going to take a pipette and put a little bit of both onto separate slides. So we'll take a drop of our minor and put it on a microscope slide, and a drop of our major on a microscope slide, and put a cover slip on the top of both, and look at it under the microscope, see if we see any agglutination. If there's no agglutination, that means that they are compatible for a blood transfusion. So I'm going to look at our minor first. Oh, dropped it. I'm actually going to make a new minor slide, just since we dropped it. just to be safe. And we're gonna look under on that under low power. I'm going to bump up to a higher power. Okay, so it looks like I'm not seeing any auto-agglutination in here. All of our erythrocytes are independent of each other. So I'm not seeing any stacking. So I'm not seeing any agglutination in the minor. So still looking through, it's all evenly dispersed on the minor. So now we'll take a peek at the major. Make sure we don't see any auto-agglutination there either. And again, gonna start at the lowest power. So on low power, doesn't look like there's any auto-agglutination. And I'm not seeing any stacking on the major either. All the erythrocytes are independent of each other. Not seeing any stacking at all. And I just want to double check that on the highest power.
How's everything going? Good. Do you have a school schedule for next semester?
I have Yoda here for Dr. Shopper. Yoda here for Dr. Shopper.
And didn't see any stacking there either. So final evaluation, no auto-agglutination grossly or microscopically. Groot would be an appropriate donor for Ellie if she ever needed a blood transfusion. No auto-agglutination present.